All right. Well, welcome, See With Faithful. Excited to see everyone this morning, afternoon, or evening, depending on where you're signing in from. I hope everyone had a great time at the CWIS annual conference. It's great to see so many new faces and old faces here at the CWIS Case Review Series today. Before we get started, just a couple of rules of engagement. First and foremost, questions are encouraged. Any and all questions we will try and address. Please feel free to put them in the chat box or after the presenters have presented, feel free to speak up and ask your question. The more questions that are asked, the more we all learn. So it's a win all around. For those participating in the call, please make sure you're on mute during the presentations if you're not presenting. The way you'll know you're on mute is if the microphone on your screen is red with a cross through it. Finally, the format, there's about 5 to 7 minutes for each presentation and then 5 to 7 minutes for questions for each presentation. Also, just a quick note, please register for the next CWIS Case Review Series. The link's down below. And we also have copies of all prior CWIS Case Review Series there as well for you to be able to review. With that, I am going to stop sharing and hand over to Dr. Gerald Baltazar, who's a trauma surgeon at NYU Langone Hospital in Long Island, who'll be giving us our first presentation.
Thank you so much, Dr. Forrester. I appreciate the opportunity to give this quick talk, and I'm glad to represent NYU Langone Health here. This is a case of a crushed chest, a crushed heart, and a crushed back with a lot of complexities that led us to have some fun decision making. And let's get rolling. This is a 45-year-old male who was exiting his workplace when he was struck by an intoxicated driver driving on high speed. It was a level 1 trauma activation. He has no significant past medical history, surgical history, or social history. He hasn't seen a doctor in a long time. Per EMS, he was trapped under the wheel of the car, as illustrated here, requiring extrication, and the car wheel actually landed and was seated onto his chest in just about this angle, as you can see, crushing his heart. He ended up in having the thoracic injuries that included an oblique sternal fracture at rib space 3, costal cartilage left 4 through 7, and a series of left lateral 4 through 7 fractures, which constituted a flail segment, and a series of right anterior 2 through 5 and lateral right 6 through 7 fractures. Though, as you can see here in the picture, the blues are representing undisplaced simple fractures, and the reds are offset simple fractures. And as you can see, the majority of the fractures are overlying the precordial space, which suggests that he was going to have some cardiac abnormalities, which in fact he did. Here are some of the representative images. On the left image, you can see the sternal fracture, and you can see that it's oblique, which would make would bring up some concerns for making sure that we had enough space for both cortex of the bone to be approached from the screw. You can see some of the fractures that are more lateral here on the rib through the image in the middle, and you can see the cartilaginous fractures represented on the image to the right. He did have some cardiac injury. In fact, he had a blunt cardiac injury with a troponin that peaked at 0.78. At our institution, 0.04 is already elevated. He required about 72 hours of pressor support for that cardiomyopathy, and ultimately was weaned off of the pressor support. He also had moderate bilateral pulmonary contusions, bilateral hemopneumothoraces. You can see in the chest X-ray above, he got bilateral chest tubes, and he also had a moderate TBI. And interestingly, which complicated our operation, L2 through 4 complete, L2 and L4 complete burst fractures, and an L3 compression fracture with multi-level transverse process fractures constituting, as you can see here on the right, an unstable spine. 4 days after the injury, he was taken to the OR for his thoracic stabilization operation. There was a lot of coordination that occurred in those 4 days with spine surgery. It turns out that, not unexpectedly, the patient would need to be prone for several hours to do the spine operation, and he was too unstable to turn lateral decubitus and make the typical approach for the lateral fractures. Given the complexities of these injuries and that we had some time while we were stabilizing him from a hemodynamic perspective, we checked in with some of our vendor specialists to get some information about how best to approach this patient. And we decided ultimately that an anterior approach was our only possible approach, but we decided to do as minimal approach as we could possibly do in order to protect the heart from any further damage while prone. And we decided to make our approach through a sternal, extending through inframammary incision as illustrated in blue here on the figure. This would allow us access to enough of the anterior fractures and potentially some of the lateral fractures such that we were able to protect the heart when the patient is turned prone. Although this would not clearly allow us to manage all the fractures and optimize his respiratory mechanics, it was what we were able to do in the time that we were and with the condition that he had. So we went to the operating room, we reduced the sternum, and we placed a train tracks plate over there. It had to be a little bit elongated because, again, the middle part of that fracture was oblique and we couldn't traverse it easily with both cortices. We attempted to reach the lateral fractures, but it was not feasible from the incision that we had, despite the fact that we tried to extend pretty laterally. So we made a lot of effort to bridge as much as we could of the sternum to the ribs across the cartilaginous fractures. And as you can see, the rib 7 was also fractured at the cartilage, but there was just not enough landing zone to put enough screws at the sternum at that point. And so we left that one alone. This managed to get him stabilized enough that he was able to go to his prone spinal surgery successfully on post-op day 2 from the stabilization of his chest. He was ultimately extubated at post-op day number 7, which was, all things considered, quite successful, especially given the fact that he had the underlying pulmonary contusions. His post-op course was complicated by an ARDS picture, but that resolved fairly quickly. Seizures related to the TBI, colitis, pain syndrome, somatic dysfunction. Ultimately, he made a full recovery, and this is one of his follow-up CAT scans. As you can see, all the various pieces of metal that have rebuilt his body. And there are several learning points that I think can come out of this case. It's really a very complicated case of chest wall injury with all the other polytrauma and pulmonary and hemodynamic issues. We had to focus initially on the hemodynamic and pulmonary stabilization, as one might expect, before proceeding to the operating room. And because we weren't forced to really only keep him on his back and approach from a supine position, and our approach was quite constrained by his other injuries, we chose a very minimally operative approach. And in order to get to that, we did use judiciously educational resources, extensive imaging analysis, and what one of my mentors back in the day used to say, we made perfect planning to lead to a perfect procedure. And he did have a good outcome with a combination of sternal and rib ORIF approaches. And we maximally used the limited landing zones for the plates, which from a technical standpoint was probably the most interesting thing about this case. So again, thank you very much for the time, and I'll be glad to answer any questions or be part of a discussion.
Excellent, Gerard. Thank you.
Joe, can you hear him?
Yeah, it looks like we got a bunch of questions from the chat. 3 out of the 4, or at least from what I can see so far, all have to do with how you or did not attach the plates to the cartilage. So a question from Dr. White, maybe to start it off, and then we'll move down the list. Did you end up putting any screws into the cartilage, or did you use a cerclage?
We put a couple screws into the cartilage in the areas that felt a little bit still weak. If the bridge, I think on rib 6, and let's go back to that picture. I think you can see a couple going across ribs 5, and I think we just did it across rib 5 because the other ones felt quite stable without it. But you can see, I think we put 1 screw into rib 5, and I think you can see a couple screws also into rib 6.
Excellent. And then one of the other comments that was brought up was whether or not you thought about using zip ties as opposed to using screws.
I'm a big fan of zip ties. I actually published a paper on zip ties for chest tubes at one point, but no, we didn't use zip ties here. I didn't even think about it, but that's actually a good idea for future reference.
Yeah, the
Hi, Dr. Schubel.
Synthes set comes with zip ties. It's the only product line I believe that has that in there, but that doesn't mean you can't go off to Home Depot and just autoclave some.
Yeah, that's cool. That's a great idea, actually. And if I may, Dr. Schubel was actually our consultant. So thank you, Dr. Schubel.
This is the case you called me about, huh?
Yeah.
That's cool. Coming full circle now.
Yeah.
Excellent. Well, there's also it sounds like a little bit of chatter in the box about wine bottles and the relationship to your name. So I'll let you kind of go through that at your leisure. With that, not seeing any more questions about the case, why don't we swing it over to Taylor Head. Taylor is from MUSC. He's a medical student. And I also want to point out that he was the recipient of the CWIS 2021 annual meeting research prize. So on many levels, congratulations, Taylor, on your success. We'll look forward to hearing your presentation.
You guys hear me okay? Thanks for that introduction, Dr. Forrester. So like you said, my name is Taylor Head. I'm a third-year medical student at MUSC. I'm here to present an interesting case titled CPR-induced hardware failure after surgical stabilization of flail chest. I learned about this case through a project that we presented this past weekend at the CWIS Summit, for which Dr. Erickson, who I believe is with us today, was my research mentor. Before getting started, I'd just like to share that I have no personal conflicts of interest or disclosures. So we present the case of a 48-year-old male with a past medical history significant for hypertension, who presented to our academic level 1 trauma center status post a motor vehicle crash that was a T-bone with a 2 to 3 foot intrusion into the driver's side from a semi-truck. He was a restrained driver with a loss of consciousness of an unknown period of time, had to be extricated by EMS and presented to the ED with a GCS of 15. His initial presentation also included complaints of left shoulder, back, hip, and chest. Mr. H's initial workup identified numerous injuries, which included a left pubic ramus fracture, left sacral fracture, left scapular fracture, a chronic right dislocated temporomandibular joints, a left basilar pulmonary contusion, left hemopneumothorax, a small retroperitoneal hematoma without active extravasation, and flail chest with 23 total fractures. Although flail chest was identified, the initial CT report did not correctly identify all of the patient's rib fractures, and he was not originally deemed an optimal surgical fixation candidate for several reasons related to this initial imaging. First, many of the fractures were too close to the corresponding transverse process for fixation. Second, many of the fractures were in line with minimal displacement and offset. And third, the fractures involving the costal cartilage were not readily discernible. Due to the extent of his injuries, though, the decision was made to admit him to the surgical trauma ICU. On hospital day 2, orthopedic surgery was consulted and recommended non-operative treatment for his pelvic and scapular injuries. A thoracic epidural catheter was placed for pain management, and a chest tube was inserted for an enlarging hemothorax. The patient was transferred to a lower level of care, but later developed respiratory distress and was readmitted to the STICU on BiPAP. On hospital day 10, he was intubated for further respiratory insufficiency and altered mental status. A repeat chest CT scan at that time then revealed greater displacement and offset of the previously identified fractures, as well as improved visibility of the costal cartilage fractures. The table presented here shows the fracture pattern on this repeat chest CT. After Mr. H's more revealing repeat chest CT, he was deemed an appropriate surgical candidate. And on hospital day 13, he received initial open reduction and internal fixation of rib fractures on the anterior left side. Trapped lung and retained hemothorax were encountered, and the lung was stripped and released as a decortication. A chest tube was also placed at this time. Ribs 4, 5, 6, and 7 were repaired with plates. The 5th plate in particular ran all the way to the sternum to support the costal cartilage fractures. A bronchoscopy was performed at the end with evacuation of mild mucus plugging, and the total estimated blood loss was 500 milliliters. He then returned to the operating room on hospital day 15 for completion of open reduction internal fixation on the posterior left side with an estimated blood loss at that time of 300 milliliters. For both procedures, we used the same sets of plates and sternal locking screws across 6 separate ribs in 9 total locations, with at least 3 screws proximal and distal to the fracture location. Other fracture locations were not deemed appropriate for fixation due to the patient's body habitus and concern for damage to surrounding tissue. No additional procedures were performed at this time, and these procedures were without complications. The patient returned to the STICU post-operatively with a chest tube in place. Mr. H was first extubated on hospital day 16. However, his course became further complicated, and he required re-intubation on 3 separate occasions. His chest tube was able to be removed on hospital day 22, However, he suffered from a perforated duodenal ulcer that required operative repair on day 20 and subsequent abdominal wound dehiscence and abscess formation requiring operative repair on day 36. On hospital day 40, the patient was reintubated for respiratory insufficiency, but afterwards became bradycardic with PEA and required CPR with return of spontaneous circulation after 2 rounds of defibrillation. This corresponded to rib fixation post-op day 27. After his cardiac event, CT revealed hardware failure with 1 locking screw separating from a plate at the left costochondral junction and another along the sternum. Interestingly, the sternal plate had partial separation from the sternum as well. An isolated hardware failure was also noted at the posterior lateral segment of a rib close to the transverse process of the corresponding vertebra. The screw in this instant was not free to the same extent as was the sternal and costochondral segments and could potentially have been an image artifact. Unfortunately, the patient ultimately died on hospital day 56 from suspected PE rest again. So this case of CPR-induced hardware failure after surgical stabilization of flail chest provides several learning points. The table to the right demonstrates the progression in fracture pattern as well as the changes resulting from hardware placement across varying areas of the chest wall. Ultimately, the first learning point is that rib fractures are dynamic in the acute setting. Further support for this learning point comes from an original article by Baumann et al., which was published in 2020, and Dr. Erickson and I's own project presented this past weekend also supports this point. Second, with any surgical procedure, complications are to be expected. The incidence obviously varies based on the outcome that is considered, yet with hardware failure after fixation, this seems to be exceedingly rare. In a recent surgical stabilization of rib fracture systematic review that featured 35 studies and approximately 1,200 patients, only 1 incident of mechanical failure was noted with 0 cases of what they defined to be breakage. A separate multi-center study did identify 38 cases of hardware failure, and these most frequently occurred in the anterior lateral and lateral regions, with screw and plate migration as the most commonly cited mechanism. The case we present here is therefore rare and further questions the effectiveness of rib fixation in patients that later receive CPR and other high impact forces to the anterior chest wall. After reviewing the literature, we've identified only 1 other case of hardware failure after CPR. This was in an elderly female, receiving identical plates and screws in a similar distribution across the chest wall. The hardware failure in this instance was localized to an anterior plate whose screw had separated from the cortex. Besides this report, we're unaware of any major studies that have considered the impact of CPR on rib fixation, which represents our third learning point and may serve as an area for future research efforts. In particular, we suspect that our patient's change in fracture pattern, as well as the previous case report, are direct results of the chest compressions in CPR. The final learning point is that the identified hardware failure in the costal and anterior sectors suggests that the sternum and costochondral junction are dynamic areas of the chest wall, dissipating forces differently than do the bone of ribs. Future studies may also be warranted to investigate this hypothesis and provide a better understanding of fixation techniques across all sectors of the chest wall. Thank you for your time, and I will try to field questions as best I can.
All right, thanks, Taylor. Great presentation. Your presentation has definitely generated a number of comments in the chat, and we'll try and go through them. Please feel free to bump it up if anything, if you need any assistance from the person who did the case.
Right.
So one question from Dr. Lesbrance is, how well were you expecting the epidural to work given how high many of the rib fractures were?
That's a good question. I do not have any personal experience, and I unfortunately have not rotated on the trauma service. Dr. Erickson, do you want to comment on that since you were in the operating room?
Yeah, as expected, it didn't work all that great in a lot of the upper fractures. It was good for the mid thorax and some of the lowers, but still had quite a bit of upper pain.
Thanks. And then why 2 operations versus 1 operation?
So Taylor, young Dr. Head has no answer for this one, so I'll take this one. So why 2 operations? I tend to stage my operations if I have to access anterior, lateral, and posterior. I'll go in to stabilize the anterior and lateral fractures first, and then bring them back the next day to flip them prone to get to the back. What I found is that in doing them in staged procedures, they take less of a physiologic hit, similar to the general theory that 2 hours in the operating room is enough and you don't want to leave them in there for too long. I take them back for one and then flip them prone the next day or lateral the next day if I need to. So I usually stage these larger cases. Granted, absolutely no data and purely surgeon preference. And I get tired. I'm old.
Well, thanks for the honesty. I'll kind of to follow up on that question from Dr. White about the proximity of the screws to the fracture line. How close are you willing to lay screws next to fracture?
So I've never seen much of a difference between placing them close or not close. Occasionally you'll get a cortex fracture if you're too close to it, and you can kind of precipitate more breakage of the bone. This case is unlike what I do currently. Currently, I leave 1 to 2 holes open in the location of the fracture. So I'm at least half a centimeter to a centimeter away from the fracture line. And I leave those blank holes to give me an idea of where the fracture was originally as I can find it on x-rays.
Hey, guys, can I pipe in here just a little bit? I can't.
Only if you turn on your video, Tom. Hey, Everett.
Hey, man. Forgot my video was off.
Nice to see everybody. So that's an interesting reason for leaving those holes open, so you can remember where the fracture line is for future imaging or evaluation. I think there's a more compelling orthopedic reason for not putting screws immediately adjacent to the fracture. That's where most of the motion, residual motion resides. And this is what my colleagues tell me, the orthopedists, if you lock the plate down securely immediately adjacent to the fracture line, then you're transferring all of that stress, all of that mobility to a very narrow area of the plate, and you're risking plate fracture at the fracture line. They swear that's a real thing. It happens in long bones. I don't know about ribs, but for that reason, I leave at least 1 hole and oftentimes 2 holes, as you do, just to keep the screws away from the fracture line and to distribute that motion over a wider area of the plate.
Yeah, what we've seen a couple of
Comments,
times,
please.
what I've seen a couple of times, and this may just be me because I'm not as good at this as the rest of you guys are, is sometimes there's these little hairline microfractures. If the rib is fractured transversely, but then if you really look at that periosteum, you sometimes see little stellate fractures running along the rib. And a couple of times, if I've gotten my screws too close to where the fracture is, I'll actually split the rib like a piece of cordwood. And so I've actually, I know my fellows are all on here, and a bunch of the other UCI folks, we generally stay at least a centimeter or 2 away from the fractures and keep a couple holes open if we can.
So in general, as my techniques evolved over the last decade, in particular the last couple of years, longer plates, fewer screws. That's an orthopedic tenet, and I think it's something that absolutely is ripe for study, and CWIS is the right group to do it with. But that's my 2 cents.
Yeah, it's a fascinating commentary, Tom, because the only hardware fractured plates we've had in over a decade at this institution were ones where we left 2 holes open in the middle, and the fracture didn't heal underneath, and the guy fell down and fractured all of his plates. Every other hardware failure that we've not had new fractures under the locations of the plates. They've all been periprosthetic fractures. This is the second patient I've had who's had CPR after surgical fixation, and I have another patient who got hit by a car. I fixed him, and then he got hit by a car again. And we looked at his hardware failure characteristics as well. And I've never had a plate failure. I have had screws back out, but it's often periprosthetic fractures.
I agree with what you're saying. I'm not suggesting I know the answer. I think it may be system related. The more flexible plates may tend to be weaker at that point than the more rigid matrix plates. I don't know, but I think it's something we don't really understand fully. And I have had several plate fractures at fracture lines in my experience.
Yeah, I can tell you privately what system I used on the other one.
Oh, I can see your x-ray. Oh, you mean a different case? Okay.
The other case I'm talking about, I know everybody knows what I used on this one. The plates that fractured was not this patient. It was a different patient. So we can, if you're interested, message me privately and I'll tell you what system.
This is a terrific presentation. Thanks, Taylor.
Hey, before we jump to the next one, if we got another minute, Taylor, you want to give those of the folks that were on this call that did not have the pleasure of listening to your fantastic presentation at CWIS, a 2-minute version of what you guys found with the distribution of fractures and distraction over time? Because I thought that was a real solid presentation.
You're referencing from this past weekend?
Yep.
Sure. So we did a study looking at CT chest imaging of patients who presented with acute blunt mechanism of injury with greater than or equal to 1 rib fracture and other signs of severe injury that had that initial chest CT on presentation, and then a follow-up chest CT, and looked at the amount of displacement over time. And so what we found was that the ribs 4 through 6 in the posterior lateral region and those with multiple fractures per rib were most likely to have progressive displacement. And we, unfortunately, I can try and show similar to this. We used a modified system of the CWIS sectors. So I don't know if you guys can see my mouse here, but basically we sort of split off, to provide context, the posterior section listed here into a posterior that ended 3 centimeters lateral to the transverse process. So medial to that was posterior, and then we had posterior lateral. That's kind of what I'm referencing there. And like I said, those were the ones that we did see the greatest amount of displacement over time. Dr. Erickson provided a really interesting analysis with this multi-layer neural network perceptron that extends well beyond my statistical knowledge as a third-year med student, but basically was good at looking at variables with high collinearity, and showed that those 3 categories, the ribs 4 through 6, the posterior lateral region, and then also multiple fractures were most predictive of progressive offset taking place.
Awesome. Thanks so much, Taylor, and congratulations again on your award and your presentation at CWIS. We look forward to seeing a lot more high quality work coming out from you in the future.
Thank you.
All right. If you want to go ahead and stop sharing, we'll turn it over to our last presenter. All right. Our last presenter is Jeff Choi. Jeff Choi is one of our Stanford surgery residents and was the recipient of the 2020 CWIS KLS Martin Resident Research Fellowship. Look forward to hearing his presentation.
All right, thank you, Dr. Forster. Before I start, I posted a link for those of you who weren't at the CWIS. I posted a link to the app that I'll be discussing throughout this presentation. If you have an iPhone, it's called the RFF Index, and I'll be discussing the app for this presentation. Okay, so this case is a case of a 60-year-old gentleman who suffered ground level fall. And the case mostly focuses on his comorbidities and his high-risk candidacy for SURF. So he had a couple of comorbidities, including hypertension, COPD, not on oxygen, rheumatoid arthritis, plaquenil, coronary artery disease, et cetera, with CKD. So when you're faced with a patient with so many comorbidities, one of the most obvious questions is, how do you quantify the baseline frailty? And at the CWIS summits, we discussed using the RFF index to quantify frailty. So using the RFF index, we calculated his frailty score to be 41.8. And his relevant medication for this case, he is on Eliquis. So if we look at his predicted risk without a SURF, his predicted risk of inpatient mortality would be about 14%, pneumonia over 50%, chances of being discharged to home pretty low, having a prolonged hospital stay over 50%. So he's definitely a very frail patient. And his thoracic injuries range from left ribs 5 to 10. You can see some of the lateral fractures here. It's a lot more obvious on the axials, but ribs 5 to 8 were offset and 9 to 10 were undisplaced. And he had a series of undisplaced fractures in 9 and 10 as well that you can't really see well here. So he did have a flail segment in 5 to 8, but no flail chest physiology. So originally, we provided non-operative management for the first 2 days or so. Unfortunately, he was having difficulty coughing, really keeping himself ventilated despite maximal conservative management. So we offered him SURF. But given his comorbidities, we actually in the consent process discussed what his likely outcomes from his high chance of inpatient mortality to high chance of pneumonia without undergoing SURF. So the RFF index in this case was actually used in the consent process. So patient provided consent to undergo SURF. The procedure itself, we performed open SURF from left rib 6 to 8, and we also performed external cryoablation in the ribs 4 to 9. You can see in the chest X-ray here, you can see the posterior plates, the 2 posterior plates and the 3 lateral plates here. And one thing I've noticed, we do try to perform VATS to perform thoracoscopic cryoablation. In the patient's case, the lungs were adhered to the chest wall. So we tried going in performing VATS on, I think, 2 separate locations, but the lungs were too densely adhered. So we went ahead and performed external cryoablation. In terms of the post-operative course, the patient was in the ICU for a total of 5 days, 3 days after undergoing SURF. He was extubated at post-day 1. The only reason he was intubated, we kept him intubated after the procedure, was he had metabolic acidosis, and given his baseline cardiopulmonary function, we weren't sure he would be able to compensate on his own adequately. So he was intubated post-procedure, but after adequate resuscitation was extubated post-day 1, and by post-day 4, he was breathing on room air. And he was in the hospital for a total of about 11 days and was discharged to a SNF. And on 2-week follow-up, he was doing quite well. No shortness of breath, no rib pain. He did have some functional limitations, but that was mostly due to his baseline rheumatoid arthritis. And if we think back to the patient's actual outcomes, hospital length of stay was over 5 days. He was not discharged to home. We can start seeing how RFF index can really be used in clinical practice. So like I discussed last week, that the point of any prediction tool is to really try and improve patient outcomes. So we haven't proven that using the RFF index can improve outcomes, but I think this case provides a glimpse of how we might be able to test this going forward. So one way we can definitely use the RFF index, especially for patients with high frailty burden, is to figure out how to triage patients. So instead of just relying on an age, one number, and their injury patterns to decide whether or not to send patients to an intensive care unit, we can also incorporate their frailty. So for example, a patient who has pretty minor injury pattern, but high baseline frailty might warrant the monitoring in the ICU. And of course, where patients may be triaged to would depend on your hospital settings. And also, especially for discharge planning for elderly patients, I think the RFF index can be really helpful. So for example, in this case, if we predict that the patient essentially has close to 0% chance of being discharged to home, we can work with case management and social workers to work on appropriate discharge planning. I think really the next step, one thing to keep in mind is the RFF index was developed for a national cohort of patients, most of whom did not undergo SURF. So you can think of this as like, what are the predicted outcomes if you do not undergo SURF? So prospectively, if we contrast patient's outcome that's predicted using the RFF index for those who do and do not undergo SURF, I think we'll be really able to quantify what's the benefit of SURF among frail patients. All right, so that's the end of the case, and I'd be happy to answer any questions about this case or the RFF index.
All right, Jeff, we got some questions coming in from the chat. So a question from Dr. Schubel: why wait 2 days on a flail?
All right, good question. So the patient had flail segment, but not flail physiology. I believe it was mostly, and Dr. Forster, please feel free to correct me if I'm wrong, but I believe the reasoning was because we want, just given the comorbidities, we were trying to minimize, we're trying to avoid an operation. So we did try escalating, we have escalation steps for analgesia. So we escalated all the way to serious anterior blocks. We couldn't provide neuraxials because he was on Eliquis. But essentially it's 2.5 days, but essentially on the morning of the second day the patient was in the hospital, we had a long discussion about SURF and decided to provide SURF. I don't know if you have anything to add, Dr. Forster.
Yeah, it's just part of our institutional guidelines for surgical stabilization. We have the expectation that patients with clinical flail chest will go to the OR as soon as possible for stabilization, but for patients with radiographic flail chest, we also have to demonstrate failure of medical management and some sort of escalating physiologic dysfunction. So it's just our institutional policy. The question from Dr. White, why no thoracostomy tube? And I think you addressed this a little bit, but.
Yes, it's mostly because the lungs were adherent to the chest wall. I believe there were 2, if not 3 attempts to gain entry into the pleural cavity, and we weren't able to.
Yeah, his lung was completely stuck up. I got in, created a small air leak, which is why I left the that sub-Q drain. I don't normally use sub-Q drains, but that was why that was there. And then another question from Dr. Schubel. So are you using the RFF index to determine ICU versus floor, or SSRF versus non-op?
Great question. So we haven't integrated RFF index formally within our institutional guidelines yet. However, I think it certainly can be used to decide on top of the injury pattern to decide floor versus ICU. I don't think it can be used to decide between SURF and non-SURF quite yet, because it hasn't been validated to address that specific question. But I think it can certainly, obviously, if you can show that the patient's risk of certain outcomes just based on their frailty alone is really bad. And I think we know the injury patterns that definitely benefit from performing SURF. Even with a patient with a risk of with high frailty, I think you can be nudged to provide to offer SURF, just given how high the predicted risk of certain adverse events are.
So here's the follow-up question then. A high frailty patient, better or worse to plate them? And I would reference the Octo study if you're for some information on this front.
That's a great question. I'll need to review that study and follow up the Octo study.
I will say that in our, for us, at first, I was pretty hesitant to plate these super old, frail patients. But as we've gotten, both myself as well as our institution has gotten more comfortable with plating, I've become increasingly more aggressive about plating the elderly patients who fall, because I think they end up doing so much better. We have another patient who's like 86 and all sorts of medical comorbidities, and I am convinced that he would have died if we hadn't given him surgery. So just to see if there's any additional questions, I'm not seeing anything new coming into the chat for any of our presenters. I'd like to end this case review series then and thank everyone who attended, both the presenters as well as those who were in the audience asking questions. It was awesome. There was a ton of great discussion. Also, just a note, you can register for the next case review series online with the link that's on your screen. And also just want to make sure that everyone's available or aware of the other options that are available out there for additional learning about chest wall injury. We have the Ribcast and Riblets are available, and the fracture lines available weekly. So with that, again, I'd like to thank all of our presenters, all of the people joining in who asked questions, and make sure you all tune in next month for the next case review series. Take care. Oh, and Adam says, if you're not a member, join CWIS.
Thank you.